some of the HIV of the officials claim that it wasn't a co-piloted platform, in the sense that they felt that the Tribal Action Campaign took over SANEC, and also it took over the Department of Health, especially with the ministry under Barbara Hogan, who was the interim minister between 2008 and 2009, because Barbara was seen as an ally of Treatment Action Campaign, and that provided a bridge or a leverage for TAC to be able to influence quite a lot of the treatment guidelines at the time. Everything sounded like it was everything that TAC had called for. So that transition period built a bridge, a very important bridge between the state and the movements, but at the same time there was a downside of it. The downside is that you could not see now who was the state and who was the movement, because it was so entangled in the relationships that there were private meetings between the state and the activists, and the activists on the ground were becoming suspicious. So activists on the ground, meaning the Kailicha comrades and the Lusikisiki comrades, clearly articulates in the interviews that they started asking for no private meetings because they were fearful of the day when it comes where the Minister of Health is no longer Barbara Hogan, and that the new president might change, and that this is maybe tendencies of co-option. Let's be careful of tendencies of co-option, because these nice cozy relationships at national level are not translating to the ground level. At ground level, they're still faced with a confrontational state at provinces, where sub-provinces are still resisting to implement the ART program. So we cannot have a cozy relationship at one level and not a cozy relationship at another level. So that internal democracy within the HIV movement allowed the leadership to be aware of the local issues, that they cannot forget that as much as Barbara is a good minister, but that good ministry should also infiltrate that it should also apply to what is happening on the ground. But at the same time, as there was that transition shifted to some tendencies of co-option, but it also went to some diluting of the TAC demands. One of the areas that the local activists felt that is that now we started losing our own ground in terms of forcing the state to drop or maybe abandon the accreditation program. Because even under Barbara, the accreditation process still continued. Even though there was this causal relationship, what activists call it the honeymoon period. Even during that honeymoon period, the accreditation was still a challenge at local level. And comrades on the ground, we still had to fight the state to lift or maybe abolish the accreditation program. But there's a trigger that made that honeymoon to be cut short. When Free State moratorium hit the wall, when about 30 people with HIV died a day because the Free State government had issued a moratorium on all HIV programs because they ran out of money. That's when then the Treatment Action Campaign realized that its relationship and close relationship to the state was not just detrimental to the movement, it was also detrimental to the state, because if there is no watchdog or no independent voice that actually continues to monitor what happens on the ground, things could fall apart. Then TAC started to distance itself from the Department of Health, and it started monitoring on the ground much more robustly. And through the Civil Society Monitoring Forum, they were able to claim, that these are the correct numbers of people on treatment versus what the state was telling the public. This is the numbers, and in most cases they were disputing the numbers because they were not true reflection of what was happening on the ground. And so the co-option process continued, as you know, that the ministry changed. Again, Barbara left and the new minister came forward, and the new minister, Aaron Motsoaledi, was much more passionate about HIV, also seen as a friend of civil society. But that continues to put more tension and challenges in the strategies of Treatment Action Campaign, because now the new minister did not just master or continued with what Barbara started. He upscaled to a point where he mastered the language of civil society. As some of the people I interviewed said, the dilemma began and it became much more clear when Motsoaledi took over. Because when Motsoaledi took over, he didn't just wait for civil society to push for change. He himself pioneered and championed change. We have today the best HIV policies. We have the best guidelines, treatment guidelines, to the point where aligned to the World Health Organization guidelines. But at the same time, as the HIV program, HIV policy was becoming much more up to date, implementation was falling apart on the ground. Lusikisiki was the second trigger after Free State, where there was a stockouts of medicines that began in 2012. From 2010, 2012, we have had a lot of stockouts. When now the HIV movement had to change its approaches, because now it had to become much more technical in understanding implementation, not just to understand implementation from an abstract level. Now it had to understand a supply chain. It had to understand more how do these medicines actually how are they procured? If they are procured, who are the drug companies and what is their drug stock levels and so on. So what stock levels should be the moderate stock levels that should be kept at clinic level, and issues around demander codes in Lusikisiki, for example. The clinics had to only get medication from one central hospital, whereas now the movement had to now advocate for demander codes, which we had no idea what demander codes were before 2003. So as the movement moved forward with the implementation, the more it got into implementation, the more technical implementation became. They had to understand budgets. And the technicalization of the movement is both a good thing, because it means that the capacity within the movement is growing in terms of understanding implementation and its complexity. But at the same time, the movement itself was not moving fast enough as the HIV program was moving. Fast enough in the sense that the HIV program, as it was shifting, the health system wasn't shifting fast enough. For example, the delivery mechanism for the HIV program is not vertical programs. It's through the horizontal program, meaning that you cannot have an HIV program without a functional health system. Or you cannot have a functional system and not have an HIV program. So the function of the public health system and the HIV program go hand in hand. That's when I think the HIV movement began to really struggle in advancing, but also in the evolution of its tactics are not moving fast enough. Still using the same tactics and same strategies to apply that they applied in HIV programs, which is vertical, and now applying it in demanding change in the public health system. And there are clear indicators that it's not clear whether that is being effective. From what people that I've interviewed is that litigation and marches and so on, how far can they shift the public health system? Should maybe the HIV movement start thinking about other tactics and strategies in which they can shift change and transform change in the public health system in order to deliver a quality HIV program? What would be some of those strategies and how they should look like? But it's clearly now that the HIV program is becoming much more matured, in the sense that now it's no longer the issue that people will not have access. People will have access, but the problem is that the mechanism in which access is being delivered, meaning the public health system, it's not able to provide adequate and quality health care. And what then should be the role of the HIV movements in making sure that the health system is able to deliver. And I conclude that currently the HIV movement tactics have not changed. And for as long as they have not changed, or at least to adapt to the new challenges of today, they will remain questionable whether they are effective in dealing with the health system in relation to how the health system needs to deliver quality health care. And that applies not just at national level, but also most likely at provincial and at district level. That the comrades on the ground are already shifting, but the national movements have not shifted in framing how they are broadening the scope because the scope is broadening on the ground. On the ground, comrades are saying clearly that they could not just talk about antiretrovirus without talking about nurses and capacity of the human resource capacity of the clinics. For example, in Khayelitsha, clearly they've challenged issues of norms and standards, the cleanliness of clinics, the attitudes of nurses, the availability of beds in district hospitals, and so on. That is beyond what was seen as the scope of the HIV movement before 2003, because implementation forces the activists on the ground not just to look at HIV narrowly, because their members are not just people living with HIV. Their members are people who are using the public health system and are using the HIV and the HIV movement as a channel to influence change and influence implementation, but also as a channel to hold the state accountable for the services that they provide. So it's questionable whether their tactics are being effective. So in a nutshell, it would have been a missed opportunity if as scholars we only ended our analysis at 2003.